Hello, my name is Dr. Warner Huh from Birmingham, Alabama. Today we're going to talk about HPV vaccines and prevention strategies against HPV-related malignancies. I want to take the time to recognize the CDC for sharing many of their slides with me today. They have an ongoing campaign to raise awareness related to the HPV vaccine and reducing the incidence and mortality related to cervical cancer and other HPV-related cancers in this country. I think we have a real unique opportunity to make a real difference in women in terms of eradicating cervical cancer and other HPV-related cancers from the United States as well as worldwide. Both with screening and with this HPV vaccine, we can do that. And in this video, we're going to talk about the vaccine itself. We're going to talk about the natural history of HPV. We're also going to talk about coverage in the United States as well as the impact. So hopefully you'll learn a little bit about the vaccine, a little bit about HPV, and what we can do to really reduce what I would consider to be a terrible disease from the United States. Thank you very much. So, to understand HPV prevention, you still need to first understanding the burden of disease and some of the natural history related to HPV infection. So most females and males at some point in their life will be infected with HPV. It's by far the most common sexually transmitted infection in the U.S. and worldwide, and it's estimated almost 80 million Americans are currently infected. There are about 14 million new infections per year in the United States, and HPV infection is most common in people in their teens and their early 20s. And what's important to recognize is that most people never know that they've actually been infected with HPV. So what we commonly tell our patients is that it's a virus that's easily acquired, but also easily eradicated, and up to 80 to 90% of women will actually eradicate their vaccine spontaneously over approximately a 2-year period. So when you actually look at cancers that are attributable to HPV, obviously the biggest one on our minds and our list is cervical cancer, but there are numerous other malignancies, both in men and women combined, that are attributable to HPV, including oropharyngeal cancer, anal cancer, vulvar cancer, vaginal cancer, and penile cancer. And another important disease to recognize that's also related to HPV is genital warts. This is a highly prevalent and common condition. It's not malignant, but it commonly afflicts younger women and is a major target for the HPV vaccines. So cervical cancer. Cervical cancer is the most common HPV-associated malignancy in women. There are about approximately 500,000+ new cases and approximately 275,000 attributable deaths worldwide in 2008. And this is perhaps underreported, since not all countries equally report their new cases of invasive cervical cancer and their deaths. In the United States, there are approximately 11,000+ new cases a year and about 4,000 attributable deaths related to cervical cancer in 2011. And I think it's important to recognize that approximately 80 years ago, that cervical cancer was by far the most common malignancy in women. It actually was more common than breast cancer, and this is the impact that screening has had in terms of reducing the new cases of cervical cancer in the United States, essentially since World War II. About 1/3 of cervical cancers occur in women who are between the ages of 20 and 44. About 13% of those women are between 20 and 34 years of age, and 24, about 1/4 of those women, are between 35 and 44 years of age. So it's clearly a disease and cancer that afflicts typically younger women. When you actually look at HPV-associated cervical cancer rates by race and ethnicity, clearly what we do know is that there is a higher rate, particularly in African American women. And not only is there a higher rate, there's actually a higher rate of mortality seen in African American women as well. And many of us have actually looked at why, and this is not just solely due to absent or lack of screening, but there are clearly risk factors related to African American women that put them at greater risk for cervical cancer, but also a greater risk for death related to cervical cancer. And actually, when you look at cervical cancer incidence rates by state in the United States, what you'll see is an interesting distribution. There's a higher rate seen in the Southeast, in the Midwest, particularly in the Appalachia states, and also well as in the Southwest, particularly Texas. And these are areas where we know that basically cervical cancer has a much higher rate per 100,000 women. And all these also happen to be states where we have issues with screening, or women that maybe perhaps be underscreened in the United States as well. So to kind of give you an idea, if we didn't vaccinate women and men in this country, this would be the annual burden of genital-related HPV diseases in U.S., particularly in women. And what we would have is about 3 million cases and about $7 billion spent a year on HPV-related genital diseases. And at the very bottom of this pyramid, it's roughly 1.5 million new cases of what we call low-grade cervical dysplasia. This is dysplasia that very rarely ever goes on to become a more severe dysplastic or severe precancerous lesion or cancer, but is a common cause of triage and evaluation by the healthcare provider. There are about 1 million new cases of genital warts every year, and this is probably grossly underreported as well. And approximately 330,000 new cases of HSIL, or what we define as precancer, high-grade cervical dysplasia. These are cases where we typically will treat or recommend treatment, particularly in older women, so that they don't go on to develop cervical cancer down the road. And at the very top of the period, approximately 11,000 new cases of cervical cancer and approximately 4,000 cervical cancer deaths seen in the United States. So again, there's a pretty significant impact, healthcare impact, related to HPV-related diseases, and this kind of puts the framework in terms of why vaccination in this country is potentially important. So let's talk specifically about the HPV vaccine and some of the evidence that goes in terms of HPV prevention with this vaccine. So HPV prophylactic vaccines, at least the ones that are FDA approved in the US and worldwide, are known as VLPs, or quote-unquote virus-like particles. They're non-infectious, they're non-oncogenic, in other words, they don't cause cancer, and they're basically empty type particles in which they don't contain any DNA. What's very unique about them is they have almost an identical outside structure or coating or envelope that might be seen with a real HPV particle. But again, these virus-like particles really induce a very high level, what we call neutralizing antibody. And these neutralizing antibodies are what ultimately will protect a woman and a man from HPV diseases and infection alike. So there are two HPV vaccines currently on the market. One is the quadrivalent vaccine and one is the bivalent vaccine, and they're produced by different manufacturers. The quadrivalent vaccine protects against 4 different types: 6, 11, 16, and 18. 6 and 11 are the more common types that cause genital warts, and 16 and 18 are the more common types that cause cervical cancer. Approximately 70% of all cervical cancers worldwide are caused by 16 and 18. In the bivalent vaccine, the types are just restricted to 2, 16 and 18. For this bivalent vaccine, it's actually FDA approved specifically for women. It's not approved in men, whereas for the quadrivalent vaccine, it's approved both in females and men. The dosing series are very similar. They both have 3 dose series, and the CDC and the ACIP have actually harmonized these so that roughly you can get them at 0 months, 1 to 2 months, and 6 months. But the main series revolves around 3 separate injections. So the Advisory Committee on Immunization Practices, or the ACIP, works through the CDC and makes recommendations nationwide for how we should vaccinate children and adults in this country. And again, what we currently are recommending is routine HPV vaccination for both males and females at age 11 and 12. We also recommend vaccination between the ages of 13 and 26 for males and females, and the vaccine can be given as young as 9 years of age, but for males and females. And a common question we get is, why 11 and 12? Well, the reason we've picked 11 and 12 is because ideally the vaccine works best before boys and girls hit their sexual debut, and that's why we target 11, 12-year-olds. Well, we do still recognize value in vaccination even after the sexual debut, and that's why it's approved up to 20. One of the reasons why it's approved up to 26 years of age. So I think the most important message that we need to deliver to patients, parents, and children is that the HPV vaccine is legitimately an anti-cancer vaccine. And what we've seen is that in this country is a reduction in the prevalence of vaccine-type HPV by almost 60% in girls 14 to 19 years of age, with a vaccination rate of just approximately 30%. And we'll get into some of those issues later on. Now, we have what I would consider to be an extraordinarily low vaccination rate compared to other developed countries. And because of this, we actually are basically allowing girls and women to go on to develop abnormal pap smears, genital warts, and in the worst case scenario, cervical cancer. And many of these cases would be prevented if we could legitimately reach an 80% vaccination rate. And finally, for every year that we delay increasing vaccination rates to this level, approximately another 4,400 women will develop cervical cancer. And I think it's important to recognize that both with screening and vaccination, we have a very legitimate strategy in terms of eradicating a cancer in the United States and worldwide. And again, by not vaccinating girls and boys, we lose yet again another opportunity to prevent cancer in this country. So let's talk about the impact of the HPV vaccine. Why is this important? Well, originally, a lot of our data came from large clinical trials, and those clinical trials ultimately led to FDA approval. But now we actually have what we define as population-based benefit related to the HPV vaccine. So there are studies that suggest that HPV vaccine is long-lasting, and at the present time, there's no evidence of waning immunity. And this duration of immunity is an important issue for a lot of people. What they want to know is, do you need a booster down the road? How long will my daughter or my son be protected? And what the available evidence indicates that protection is at least lasts for 8 to 10 years. At the present time, we don't have data beyond that, but we are acquiring more and more data as time goes by. But again, we have no concrete evidence of waning immunity or men and women developing disease despite being vaccinated. Now, there are multiple cohort studies that are in progress to monitor the duration of immunity, so we'll actually gain additional information in the future years about whether or not there is potentially waning immunity or continued immunity with this vaccine series. So when we monitor impact, we look at 3 different outcomes, and they're broken down in 3 different time frames. Early outcomes, or years, might be the prevalence of HPV, or the actual viral infection, or the presence of genital warts, which we talked about, which is a non-malignant disease, but one that commonly afflicts younger women and can be highly problematic. Mid-outcomes would be restricted to years or decades, and these would include women with precancers. And late outcomes, which are decades, really look at specifically HPV-associated malignancies, and as an example, cervical cancer. So we're going to specifically concentrate on early outcomes because, in essence, it's really too early to comment on what the mid-outcomes are and the late outcomes are related to the vaccine, since the vaccine was just FDA approved in 2006. So this was a study that was published by Lori Markowitz, and Dr. Markowitz works at the CDC. And in 2013, she published this study, which basically demonstrated in a specific cohort of girls that they saw almost a 60% decline in the prevalence of 6, 11, 16, and 18, which are, again, the HPV types seen in the quadrivalent vaccine, compared to 2003 to 2006, compared to 2007 to 2010. And what this really demonstrates is a couple things. One is that we were very surprised by a very substantial decline in HPV types that are seen specific to the quadrivalent vaccine. But more importantly, the fact that only about 30% of girls in this study were actually vaccinated. So again, if we could see such a marked decline, can you imagine what would happen if we actually reasonably vaccinated girls and boys up to the 70 or 80% level? And what we would anticipate is even a more substantial decline related to HPV prevalence for those types that are very specific to the quadrivalent vaccine. But for me, I think this is probably the single most important study out there. Australia really had one of the most widespread and aggressive vaccination campaigns for women when the HPV vaccine was approved. And in their country, they've been tracking the prevalence of genital warts. And what they've noticed essentially since 2007 is approximately a 90% plus decline in the prevalence of genital warts in women. What they've also seen is a very substantial decline in genital warts in males or men as well. And this is really, in my opinion, probably the single most important study to come out related to the HPV vaccine in the last 2 or 3 years, because now we have clear-cut population-based benefit of the vaccine. The vaccine works. It's no longer theoretical. And what we're going to probably see down the road is pretty substantial declines in precancers as well, and decades down the road, hopefully declines in cancer. So for me, this is proof that the vaccine works, and the vaccine works extraordinarily well in a very short period of time. But the caveat being is that as long provided that you vaccinate girls at a very high level of coverage. If we don't achieve that high level of coverage, we might not see the same effect in other countries, particularly in the United States. So what does this coverage look like? Well, when you look at other vaccines like the meningococcal vaccine or Tdap and HPV, and this is specific to women only, and you look at, from 2006 and compare to 2007, what you see is that we're not vaccinating very well. We're vaccinating only at a rate of about approximately 25% based on this National Immunization Survey. So arguably, we're not off to a very strong start. And to kind of put this into context, I think that hopefully the viewers will appreciate this slide. So there are approximately 26 million girls, and these are the number of girls under 13 years of age in the United States. And, the 168,000 girls or women will actually develop cervical cancer if none of these girls are vaccinated, and approximately 54,000 of these women will eventually die from cervical cancer if none are vaccinated as well. Now, for each year that we state at 30% coverage instead of achieving 80% coverage, approximately 4,400 women will not be prevented from future cervical cancer cases. So again, I think it's important for the audience to recognize that this is a big deal and that we have a clear-cut prevention strategy that targets a very specific cancer that is very common in women that we could seriously eradicate from the face of this earth. And both with screening and prevention and vaccination, this goal is distinctly possible. So a couple things I think is really important is that the HPV has been proved to be safe. We get a lot of safety questions related to the vaccine, and the HPV vaccine is arguably perhaps one of the most scrutinized vaccines, both in the medical literature as well as by the lay press and public. And I'm here to tell you that there are numerous studies that have demonstrated that the HPV vaccine is safe. I've demonstrated that it's very effective. The clinical trials have demonstrated substantial protection related to the vaccine, but what we're also seeing is substantial protection in these population-based studies, including the one I just presented from Australia. And lastly, we have demonstration that we've demonstrated that the HPV vaccine actually lasts, and there's no evidence of waning immunity. So I think it's really these three things in combination that we need to recognize that we have a clear-cut strategy in terms of preventing cervical cancer and other HPV-related malignancies, both in girls and boys, men and women combined, and that's something that we need to consider very seriously because our vaccination rates, in my opinion, are low and perhaps appalling. So again, the HPV vaccine is cancer prevention, and you are the key. Okay, and I think it's important to recognize that the science backs the HPV vaccine in terms of a prevention strategy, but again, we need to get this message out. So again, thank you for your attention. I want to take the opportunity to recognize the Foundation for Women's Cancers for this opportunity to submit this video. It's a real honor. And again, I hope both patients and parents out there recognize the value of HPV vaccination. Our goal is really just to take a terrible cancer and remove it from this earth and to really improve the lives of women. And with this vaccine and with screening, I think that we have a real opportunity to do that. Thank you very much.